Good afternoon, everyone. I'm Dr. Jenny's October, and it's a pleasure to introduce Dr. Inge van Balkom. She is the head of research and director of Young's Department of Mental Health and Autism of Lentis Psychiatric Institute. She's also a senior researcher at Rob Giel Research Centre, Department of Psychiatry of the University Medical Center, Groningen, Netherlands. She was the founder and director of the first outpatient child psychiatry service established in Aruba, serving Aruba and the other islands of the Dutch Caribbean. Her research and clinical work focus on behavioral issues, including suicidal behaviors, as well as on developmental domains in neurodevelopmental disorders and rare genetic syndromes with autism phenotypes. Without any further ado, Dr. Van Balkom.
Thank you for this introduction, Dr. October. Nice to see you there. Welcome to those attending this talk. I would also like to thank the organizing committee for inviting me to present on suicidal behavior in adolescents. And I hope this will be a somewhat more clinical and practical presentation with some theoretical background. Before I start, I would like to show this disclosure statement. All speakers, I receive research and grant support and speaker and trainer fees, but these all go to my department. This is an overview of the topics I would like to discuss today. After a short introduction, we would go on to define suicidal behavior and adolescence as a developmental period. Some discussion on understanding the dynamics in adolescent suicidality, statistics, risk and protective factors, psychiatric issues with an example of autism, and implications for clinical assessment. The educational objectives for this talk include a description of the developmental perspectives on brain development in adolescence, improve understanding of risk and protective factors, as well as warning signs for adolescent suicidality and suicidal behavior, and some implications for clinical assessment for suicidal behaviors. If you have questions during the talk, please let me know. I am unsure if I can see hands or something, so I hope you can just signal and I'll possibly notice it. Otherwise, we can do this at the end of the talk. Suicide is a leading cause of death, and globally it is the fourth leading cause of death in adolescents between 15 and 19 years old. Suicide is usually preceded by a range of behaviors that may include thinking about suicide, planning for suicide, and attempting suicide. For every completed suicide, there are more than 20 failed attempts. Suicide is preventable, and early risk detection is a critical prevention strategy. Risk for completed suicide is highest in those with mental disorders, unrecognized or untreated mental illness. Suicide is a conscious, deliberate act carried out by an individual to end one's life. The ability of clinicians to accurately assess suicidality may have been compromised by different descriptions and terminology of what constitutes suicidal behavior. Consequently, behaviors that are not suicidal sometimes are labeled as such, while suicidal behaviors may be missed, leading to misinterpretation in both clinical and research settings. Non-suicidal self-harm behaviors, such as self-mutilation, for reasons other than ending one's life, and suicidal acts are frequently mistaken for one another. Different definitions of suicidal thoughts have led to challenges for clinicians. From research, it is clear that suicidal ideations present in a waxing and waning manner, with significant fluctuations in severity and characteristics of suicidal thoughts. These thoughts and ideas may vary in intensity, duration, and character. And suicidal ideation may include everything from fleeting wishes of falling asleep and not waking up anymore to intensely disturbing preoccupations. Assessing, monitoring, and documenting pattern, intensity, nature, and impact of suicidal thoughts and ideas on the individual's life is important for mental health care professionals. Reassessing suicidal ideation frequently is also important due to its fluctuating pattern. A suicide attempt is defined as self-harming behavior with suicidal intent. Intense feelings of hopelessness about the future, helplessness, depression, or self-destructive behaviors accompany suicidal behaviors. A recent analysis of 44 studies from 2000 to 2017 of healthcare service used by suicide victims showed a reliance on primary care professionals in all countries. Only 31% of completed suicides had received inpatient or outpatient mental health services in the year before their death. 57% of completed suicide had contact with mental health services at some point during their lifetime. Primary care professionals usually have an established relationship with their patient, and they have a more complete understanding of their health history. When patients experience worsening suicidal thoughts or experience stressors that may precipitate suicidal behaviors, they are more likely to seek help from a primary care professional. Studies show that 80 to 90% of completed suicides had increased their contact with the primary care in the year and months before their suicide. 44% of those who died by suicide had contact with the primary care in their last month of life. This indicates opportunities for healthcare professionals to identify any new risk factors for suicide and offer treatment options to address modifiable factors. During their final visit with primary care professionals, 90% of completed suicides in a UK study disclosed their suicidal thoughts to their primary care provider. Assessing suicidal ideation is an essential component of suicide risk assessment for individuals, extending beyond those with known psychiatric conditions. Those who endorse suicidal ideation have a higher lifetime risk of future suicide than individuals who have never experienced suicidal thoughts, although the prediction value is only weak. While the value of suicidal ideation in predicting imminent suicide risk has not been shown, it does factor into overall assessment of protective versus risk factors in short-term imminent suicide risk. Adolescence is a theoretical construct informed through biological, psychosocial, and cultural perspectives. This critical developmental period is conventionally understood as the years between the onset of puberty and the establishment of social independence as an adult. Achieving this independence is considered the essential psychosocial task of adolescence. There is significant variability in adolescent physical growth and sexual maturation. It is influenced by factors as sex, race, body mass, environmental influences, and overall health status. The human brain is not fully developed by the time an individual reaches puberty. Between the ages of 10 and 25, the brain undergoes changes that have important implications for behavior. The brain reaches 90% of its adult size by the time an individual is 6 or 7 years old. And subsequently, the brain does not grow in size much during adolescence. However, the creases in the brain continue to become more complex until late adolescence. The biggest changes in the folds of the brain during this time occur in parts of the cortex that process cognitive and emotional information. Up until puberty, brain cells continue to grow in the frontal region. Some of the most developmentally significant changes in the brain occur in the prefrontal cortex, which is involved in decision-making and cognitive control, as well as other higher cognitive functions such as social cognition. These changes are associated with a greater strengthening and a separation of brain networks in structure and function, as well as improved cognitive skills. Adolescent-specific neural reactivity to emotions and rewards, contrasted with their developing self-control skills, are thought to account for their greater sensitivity to the socio-affective context and its influence on decision-making. Fueled in part by the surge of sex hormones, the adolescent brain demonstrates unique plasticity through the strengthening of frequently used neural connections, the pruning of unused connections, and increased sensitivity to environmental influences impacting social interactions. During adolescence, cerebral myelination and synaptic pruning in the prefrontal cortex increase, improving the efficiency of information processing and strengthening connections between the prefrontal cortex and other regions of the brain. This growth takes time and it is uneven. Significant brain development continues, including progressive frontal lobe development and neurotransmitter stabilization. To understand brain development during adolescence, consider these facts from the National Institute of Mental Health fact sheet. The brain does not keep getting bigger with age. For girls, brain reaches its largest physical size around 11 years. For boys, this is around age 14. Maturation takes a long time. For both boys and girls, although the brain may be as large as it will ever be, development and maturation do not finish until the individual's mid to late 20s. The prefrontal cortex is one of the last brain regions to mature. It is the area responsible for planning, prioritizing, and controlling impulses. In a digital world that is constantly changing, the adolescent brain is well prepared to learn and adapt. It is shaped in return by experience. The big changes the brain is experiencing during adolescence may explain why adolescence is the time when various mental disorders, such as schizophrenia, anxiety, depression, emerge. The brain is resilient, but may be vulnerable to stress. Some changes in the brain, however, during this important phase of development may actually help protect against long-term mental disorders. Studies have shown that melatonin levels in the blood in adolescents naturally rise later at night and fall later in the morning than in most children and adults. This may explain why many teens stay up late and struggle with getting up in the morning. Adolescents should get about 10 hours sleep a night, and most don't get that. A lack of sleep makes it difficult to pay attention. It increases impulsivity, a risk factor for suicidal behavior, and it may also increase irritability and depression. The limbic system develops years ahead of the prefrontal cortex. Development in the limbic system plays an important role in determining rewards and punishments, processing emotional experience, and social information. Pubertal hormones target the amygdala directly, and powerful sensations may become compelling. Brain scans confirm that cognitive control, revealed by functional MRI studies, is not fully developed until adulthood, because the prefrontal cortex is limited in connections and engagement. Cognitive control is the ability to shape and constrain thoughts and actions to achieve internal goals. This area is responsible for judgment, impulse control, and planning, and it matures into adulthood. Additionally, changes in levels of neurotransmitters dopamine and serotonin in the limbic system make adolescents more emotional and more responsive to rewards and stress. Dopamine is a neurotransmitter associated with pleasure and attuning to the environment during decision-making. Dopamine levels in the limbic system increase during adolescence, and input of dopamine to the prefrontal cortex also increases. This increased activity may have implications for adolescent risk-taking and vulnerability. Serotonin is involved in the regulation of mood and behavior. It affects the brain in a different way. Known as the calming neurotransmitter, serotonin eases tension and stress. Serotonin puts a brake on the excitement and sometimes recklessness that dopamine can produce. If there is a defect in the serotonin processing in the brain, impulsive or violent behavior can result. When the overall brain system of chemicals is working well, it seems that these chemicals interact to balance out extreme behaviors. But when stress, arousal, or sensations become extreme, the adolescent brain is flooded with impulses that overwhelm the prefrontal cortex, and as a result, adolescents engage in increased risk-taking behaviors and emotional outbursts, possibly because the frontal lobes of their brains are still developing. Later in adolescence, the brain's cognitive control centers in the prefrontal cortex develop, increasing adolescent self-regulation and future orientation. The difference in timing of the development of these regions of the brain contributes to more risk-taking during middle adolescence, because adolescents are motivated to seek thrills that sometimes come from risky behavior, such as reckless driving, smoking, or drinking. And they have not yet developed the cognitive control to resist impulses or focus equally on the potential risks. The result is that adolescents are more prone to risky behaviors than are children or adults. Judgment is last to develop. Adolescents are making choices influenced by a very different set of chemical influences than adults. And they have a reward system that can drown out warning signals about risk. Adolescent decisions are not always defined by impulsivity because of lack of inhibition, but maybe because of planned and enjoyable thrill seeking. It is helpful to put all of these brain processes in developmental context. Young people need to somewhat enjoy the thrill of risk-taking in order to complete the incredibly overwhelming task of growing up. In sum, the adolescent years are a time of intense brain changes. Interestingly, two of the primary brain functions develop at different rates. Brain research indicates that the part of the brain that perceives rewards from risk, the limbic system, kicks into high gear in early adolescence. The part of the brain that controls impulses and engages in longer-term perspectives, the frontal lobes, matures later. This may explain why teens in mid-adolescence take more risk than older teens. As the frontal lobes become more developed, two things happen. Self-control develops, as adolescents are better able to assess cause and effect, and more areas of the brain become involved in processing emotions, and teens become better at interpreting others' emotions. The development of the brain even affects the way teens sleep. Normal sleep patterns are different in adolescents from those of children and adults. Teens are often drowsy upon waking, tired during the day, and wakeful at night. Biology plays a large factor in the sleep cycle. Around the beginning of puberty, most adolescents experience phase delay, later sleep onset, and later wake times. This phase delay can shift the body's internal clock back by up to 2 hours. As a result, the average teenager has difficulty falling asleep until 11 p.m. and would do best waking up at 8 a.m. or even later. Other factors that affect teen sleep are cultural expectations. Many teens take on extracurricular activities such as sports, clubs, and jobs, which often extend into the evening hours. Adolescents also have more homework, use more late-night technology, and have fewer parent-set bedtimes, all of which to stay up later than is appropriate for getting adequate sleep. Other concerns with insufficient sleep include increased likelihood for participating in risk-taking behaviors such as fighting, bullying, a greater chance of unhealthy behaviors including alcohol and drug use, and an increase of depressive symptoms and suicidal ideation. A lack of sleep may also have long-term physical and mental health consequences. Poor quantity and poor quality of sleep can lead to health concerns such as diabetes, cardiovascular disease, and obesity. Developmental models of anxiety and depression consider adolescence as an important period, especially in terms of the emergence of sex differences in prevalence rates that persist through adulthood. Starting in early adolescence, compared with males, females have rates of anxiety that are about twice as high and rates of depression that are sometimes 3 times as high. Although the rates vary across specific anxiety and depression diagnoses, rates for some disorders are markedly higher in adolescence than in childhood or adulthood. For example, prevalence rates for specific phobias are about 5% in children and 3 to 5% in adults, but 16% in adolescents. Additionally, some adolescents sink into major depression, a sadness and hopelessness that disrupts all their normal, regular activities. And although many causes include genetics and early childhood experiences that predate adolescence, puberty may push vulnerable children, especially girls, into despair. During puberty, the rate of major depression more than doubles to an estimated 15%, affecting about 1 in 5 girls and 1 in 10 boys. The sex difference occurs for many reasons already stated. Anxiety and depression are particularly concerning because suicide is one of the leading causes of death during adolescence. Some adolescents experience suicidal ideation, which becomes most common at about age 15 and can lead to suicide attempts. Suicidal thoughts and suicide attempts should be taken seriously and serve as a warning that emotions may become overwhelming. Developmental models focus on interpersonal contexts in both childhood and adolescence that foster depression and anxiety. Family adversity, such as abuse and parental psychopathology during childhood, sets the stage for social and behavioral problems during adolescence. Adolescents with such problems generate stress in their relationships by resolving conflict poorly, and they may select into more maladaptive social contexts in which depressed teens select other depressed teens as friends and then frequently co-ruminate as they discuss their problems, exacerbating negative affect and stress. These processes are intensified for girls compared to boys, because girls have more relationship-oriented goals related to intimacy and social approval, leaving them more vulnerable to disruption in these relationships. Anxiety and depression then exacerbate problems in social relationships, which in turn contribute to the stability of anxiety and depression over time. Risk for suicide frequently occurs in combination with external circumstances that seem to overwhelm at-risk adolescents. Coping with the challenges of adolescence can be more difficult due to predisposing vulnerabilities such as mental disorders. Here are some numbers I promised you earlier. 1 in 5 adolescents thinks of suicide annually. Approximately 8% will attempt it. Females attempt suicide in a 3-to-1 ratio compared to males. Stressors include disciplinary problems, interpersonal losses, family violence, sexual orientation confusion, physical and sexual abuse, and being the victim of bullying. Adolescents who complete suicide are more likely to come from a family with a history of suicide. They are also more likely to live in home environments characterized by high levels of conflict, poor attachment, and problematic communication. Adolescents who have been bullied and/or have difficulties in social interactions are twice as likely to complete suicide. Life stressors have been found to be significant risk factors for completed and attempted suicide in adolescents, particularly problems with authorities, academic difficulties, and relationship troubles, such as breaking up with a boyfriend or a girlfriend. Other risk factors for suicidal behavior to keep in mind include sexual abuse, comorbid psychopathology, physical abuse, impulsivity, which is an important risk factor, hopelessness, and poor social problem-solving skills. Gay, lesbian, and bisexual youth may be at greater risk of suicidal ideation and suicide attempt. Mental illness is the leading risk factor for suicide. And risk factors include depression, anxiety, trauma, and comorbid substance abuse disorders. Suicide risk factors vary with age, sex, ethnic group, family dynamics, and stressful life events. Risk factors are characteristics that make it more likely that individuals will consider, attempt, or die by suicide. Protective factors are then characteristics that make it less likely that individuals will consider, attempt, or die by suicide. Risk and protective factors are found at various levels. An individual level, such as genetic, or having a mental disorder, or having certain personality traits. A family level, possibly dysfunction of the family, or high cohesion of the family, which would be protective. And community and social environmental level, such as, for example, the availability of mental health services. These factors may be fixed, and then they are things that cannot be changed, such as a family history of suicide. Or the factors may be modifiable, things that can be changed, such as depression, which can be treated. Adolescent suicidal behavior may increase when experiencing conflicts at home or at school, being a victim of bullying or depressed and anxious feeling, having low self-esteem, or having experienced stressful or traumatic events such as an unwanted pregnancy or the death of a loved one. Examples for individual level risk factors for suicidal behavior include ineffective coping, insufficient coping skills or avoidance. Smartphone abuse has been investigated as a possible risk factor on an individual level, as well as poor lifestyle and disturbed sleep patterns. Family level risk factors include mental health history of parents, poor interactions in the family, and low quality of emotional ties. Adolescent relationships with peers are also associated with suicidal behavior. Having few or no close friends or having problems with peers is positively related to risk for suicidal behavior. Protective factors are factors that can reduce the likelihood of suicidal behavior. And protective factors include positive self-identity and opportunities to engage in supportive social environments, such as sports, youth groups, family connectedness, parental involvement, and positive interactions with parents and family members offers higher family cohesion, as well as positive school and peers connections and perceived availability of trusted adults. This can be a protective factor. Beliefs against suicide, spirituality and religiosity are associated with a lower risk for suicidal behavior, possibly related to effects of belonging to a community with shared values. Although risk factors and warning signs are frequently linked concepts, there are important distinctions between them. Most notably, risk factors suggest a distal relationship to suicidal behavior, indicating someone is at heightened risk for suicide, but indicating little or nothing about immediate risk. Warning signs, however, suggest a proximal relationship of immediate risk of suicide. Risk factors have been derived empirically, whereas warning signs are generally known from clinical practice and experience. Risk factors for suicide, prior attempts, mood disorders, and substance abuse indicate that someone is at heightened risk for suicide. Warning signs are only applicable to individuals, whereas risk and protective factors are found in individuals and community. Being able to tell the difference between risk factors and warning signs is important when communicating about suicide risk. Some behaviors may indicate that a person is at immediate risk for suicide. Most serious are talking about wanting to die or talking about killing oneself, talking about suicide and death. Looking for ways to kill oneself, such as searching online for means to do so. And talking about feeling hopeless and having no reason to live. Other behaviors may also indicate a serious immediate risk, especially if the behavior is new, has increased, and/or seems related to a painful event, a loss, or a major life change. These behaviors are talking about feeling trapped or in unbearable pain, talking about being a burden to others, increases in alcohol or drug use, sleeping too little or too much, withdrawing from social interactions or feeling isolated, showing rage or talking about seeking revenge, and displaying extreme mood swings. This overview from the American Foundation for Suicide Prevention summarizes the suicide warning signs. Here we see three groups: talk, mood, and behavior. In summary, talking about death and suicide, changes in mood. Changes in mood may lead to depression, may signify being sad, may lead to being withdrawn, tired, or showing emotional distress. Changes in behavior could include unexplained outbursts of irritable behavior or aggression, increased substance abuse, and actively searching for means to kill oneself. The global onset of first mental disorder occurs at younger than age 14 in 1/3 of individuals globally, at age 18 in almost half, and at age younger than 25 in 62%, with a peak median age at onset 15 years across all mental disorders. Research has shown many mental disorders have onset during biological changes in the brain, from childhood through adolescence to adulthood. Although numerous risk factors for suicidal behavior have been identified, the most reliable and robust risk factor is the presence of psychopathology. Studies have estimated approximately 90% of teens who die by suicide experienced at least one mental disorder at the time of their death, most common of which are mood disorders, followed by substance-related disorders and disruptive behavior disorders. The large majority of clinically depressed teens are not suicidal, and not all suicidal teens are clinically depressed. But approximately 40 to 60% of youth who die by suicide appear to have been experiencing some type of depressive disorder at the time of their death. Adolescents who are both depressed and have previously attempted suicide are at extremely high risk for both recurrent suicidal behavior and for completed suicide. Other forms of psychopathology linked to adolescent suicide include anxiety disorders. And although it is not a diagnosable mental disorder, the presence of hopelessness also is highly associated with youth suicide. Most youth with completed suicide have multiple comorbid psychiatric disorder and/or psychological problems. Multiple studies have reported that people with autism spectrum disorder are at a higher risk for self-injury and suicide. However, the magnitude of this association varies between studies. Individuals with autism may experience elevated risk for suicidal ideation and attempts. A recent systematic review with meta-analysis of 31 studies by Blanchard et al. Found that autism was associated with a substantially increased risk of self-injurious behaviors and suicidality. This meta-analysis found that autism was associated with more than a 3-fold increase in odds. The finding was consistent in pediatric and adult populations across geographic regions and in study design, methods, and settings. Findings suggest that individuals with autism are at substantially increased risk. Social and other impairments in autism may make the individual more vulnerable. It may lead to social isolation as well as victimization by bullying, all risk factors for suicidal behavior. It is important to systematically screen for suicidal behavior. If screened positive, in-depth assessment using a developmentally sensitive approach is important. Also, checking for comorbidities, recent stressful events, and feelings of isolation or hopelessness are important and should take into consideration the individual's social, cognitive, and communication challenges. As well as also, these need to be checked with parents and caregivers for changes. Coming to the end of this talk, I would like to summarize the key takeaways for clinical assessment. Consider and systematically check for suicidal behavior, often comorbid with depression, anxiety, and substance misuse. Are there recent stressful events and emotional problems that interfere with daily functioning? Systematically check history of suicidality. Have there been previous suicide attempts? Check your concerns proactively by asking specific questions regarding suicidal behaviors. Routinely ask about access to means, such as guns or medications in the home. And also ask the specific questions about suicidal ideation. How often do you think about it? When do you think about it? All the time or only when you are really angry? Do you want to do it? Do you have a specific plan? These last two confer highest level of risk. There are several myths regarding youth suicide which may form potential barriers to effective prevention efforts. And I would like to close this talk by busting these myths. The most significant and dangerous myth is perhaps that asking questions or talking about suicide with adolescents will increase the probability of its occurrence. There is no empirical basis for this belief. Evidence suggests that openly discussing suicide with a trusted adult can lead to beneficial outcomes. Of course, openly and calmly talking with an adolescent suspected of engaging in suicidal behavior is an essential component of effective suicide risk assessment. Other common myths regarding suicide include the beliefs that individuals who talk about suicide are only doing so to get attention and are not seriously considering it. And that once an individual decides to commit suicide, there is little or nothing that can be done to prevent it. This last myth has particular implications for suicide prevention, given that underlying it is the mistaken notion that preventing suicide or a suicide attempt is ultimately useless, because the individual will simply attempt or commit suicide at another time. Research, however, suggests this is regularly not the case. And then I've come to the end of my presentation, and I would like to thank you for your attention. These are most of the references used to make this presentation, and I am happy to take questions now. If you have a question, it might be easier for you to put it in the chat.
Hi, good afternoon.
Good afternoon.
It's not a question, it's more a comment, and just basically to thank you for your presentation.
Oh,
And
that's nice. Thank you.
thank you. It's very holistic, and I'm so glad you went through, the brain of the developing adolescent and all of that to give us a very holistic, comprehensive understanding of adolescence and mental health. So just thank you.
Yes, I appreciate that. Thank you. Thank you. Any other questions or comments, maybe?
My in-person attendees, if you have any questions, please raise your hand. I will give the mic to you. Yes, we have one question here.
Thank you.
Hi, good afternoon. My question is, what are some of the key points you would want to talk to somebody, adolescent that attempting or not attempting, but want to commit suicide and they already have the ideation? What are some of the key points you want to discuss with those persons?
Well, you would like to discuss some of the issues that you need to address, some of the issues that might be at play. So an open discussion on when are you thinking this? What exactly are you thinking about? This might be different for those with autism or ADHD or those diagnosed with a depression. But those who are undiagnosed have these comments or discuss these comments or consider life hopeless, you need to try to get them either into treatment or get a more hopeful perspective on their life. But understanding why they are thinking this, it could be things as, I am bullied at school, I have no friends, nobody likes me. It could be considerations like this. And this can be addressed in parent-child conversations, or the adolescent talks to a trusted uncle or to a trusted teacher. So it could be, and the question that needs to, actually the key points that need to be addressed are why are you thinking this? What exactly are you thinking? And we need to consider that, for example, in autism, most of the adolescents who have a serious form of autism will have a slower social emotional development. So sometimes they have misunderstandings of the social context. And you can address and correct these by discussing with them that this was not the meaning of what the person had maybe said that was considered hurtful by the person with autism. So it's important to have an open conversation. Why are you thinking this? What exactly are you thinking? When were you thinking this? These are important points. And also maybe ask, how can I help you? So a more open question, how can I help you? Do you need help to talk to somebody? Does this answer your question somewhat?
Yes, thank you very much.
Yeah, you're welcome.
And we have one more question.
All right.
How would you help someone who, well, adolescents whose parents, relatives would have died from COVID during the past 2 years?
This is a very serious issue. And it's a good question because this is something that is outside of a person's control, right? This has happened to all of us globally. And the sadness and loss that is that goes with this bereavement is different because it might be considered less because of the global issue. But for one person, this is a major loss, and it should be discussed as a major loss.
Thank you. Any more questions?
There's a question in the chat.
Yeah.
What's your advice for young couple with stress issues and stress problems? Sometimes stress issues in a relationship are connected to external or environmental influences. Is it financial stress? Is it housing stress? And sometimes these issues cannot be easily addressed. They have to do with a social environment that might not be within this couple's control. However, if it considers stress about the relationship, then discussing the relationship and expectations of the one person towards the other person can be helpful.
In my in-person audience, do anybody have any question? All right, thank you so much, Dr. Van Balkom. We really appreciate you taking your time and giving this awesome presentation. Unfortunately, suicide is a big problem. And
It is, yes.
thank you so much for your time and your presentation.
You're welcome, and good luck with suicide prevention in Guyana.
Thank you so much.
Thank you very much.
Thank
Bye,
you.
everyone.
Bye. Good night.
Good night.